while living with Chordoma. I do want to say that I do have some consulting agreements with AstraZeneca, Aspen Medical Products, and DP Clinical, but nothing from those agreements will be presented during today's session. So I just want to start because I feel like a lot of individuals actually don't know what physical medicine and rehabilitation is. And even more so, don't know what physiatry is. I think oftentimes when we think about rehabilitation, you may think about a physical therapist, an occupational therapist, a speech therapist, and yes, they are part of the rehabilitation team, but we actually do have a group of physicians who specialize in this as well. And really what we specialize in is, preventing any kind of impairment related to a disease, a disorder, or an injury. There are treatments. We help to make a diagnosis based on symptoms that an individual is experiencing. And also, we really want to treat the impairments that we are seeing. One of the best parts about being a physiatrist is really getting to understand what it is that's impacting your day-to-day and how can we help. The other really big benefit is we actually view the whole person. So we're not just treating one organ system. We're not just treating one area of the body. We're thinking about how you function as a whole. And when one part isn't working, what does that mean and how can we help? So how do we treat this whole person? Well, there's a variety of things that we can do. Some I've already mentioned. We can relieve symptoms. And when we're thinking about chordoma and we're thinking about the areas that chordoma does involve, we'll think about pain, we'll think about bowel and bladder dysfunction, we may think about spasticity. We also think a lot about sexuality and intimacy. We can help prevent further complications. We think about the idea of bone health and what does that mean in terms of fractures, particularly areas where there might have been surgeries, areas where you have experienced radiation therapy, and also just bone health during normal aging. We think about spinal instability. What is it that a tumor has done to the spinal column? How has that impacted its overall structure and balance? What does that mean in terms of posture? What does that mean in terms of any kind of surgeries that has happened? And we want to make sure that we're preventing any further injury from occurring. We think about fractures not only within the spine, but we think about fractures within long bones. And when we're thinking about these fractures, it's not only from the bone health perspective, but also what does it mean if your mobility is impaired and you're at an increased risk of falls. We think about the skin and sensation to the skin and also the impacts of immobility on the skin when we think about pressure injuries. And by having individuals get up and be mobile and be able to do more, we think about how can we prevent DVTs from immobility. We help to enhance functional independence. How do we do that? Well, we think about how did a chordoma impact the neurological system? What does that mean? Is there weakness? Is there sensory impairment? Are there cranial nerve involvement? Are we thinking about swallowing? Are we thinking about bowel and bladder? And how can we actually understand where this may be coming from? And how can we help support or how can we help an individual recover? We think about how different symptoms someone is experiencing and also neurological impairments impact function. And then we start to think about ways that we can support not only from the therapy perspectives, but how can we help with any kind of equipment? How can we help with any kind of bracing? We not only help individuals who are living with chordomas, but we actually help the treating team quite a bit. So oftentimes we can have discussions of clinical findings, not only with patients and their loved ones, but we have them with the treating teams as well. When we see something or we have a concern about something, we bring it up to the team. We discuss where we think it may be coming from. We discuss, do we think this is a symptom of the chordoma itself? Do we think it's a sign of recurrence? Do we think it's related to treatment? Do we think it's completely unrelated, but it may overall impact function? We may help with electrodiagnostic testing. And so what does this mean? Electrodiagnostics is a way for us to actually test nerves in the periphery. So we can't test the brain or the spinal cord, but we can test the nerves as they leave the spinal cord and they go into the arms and the legs. And we can understand where a nerve injury may be occurring, what kind of nerve injury that is, and provide information to the treating team about various levels or various causes. We can help with cardiovascular management. And with this, I don't mean we can help manage your blood pressure, although sometimes we do, from a hypertensive perspective, but more so when you're hypotensive or when we're thinking about how when the nervous system is involved, what does that mean for blood vessels that may not be able to constrict to help maintain blood pressure when you're up and about and trying to do things. Helping with pulmonary management. less so from a medication standpoint, but more so from a mechanical standpoint. If the chest wall can't expand or the abdominal muscles can't contract, what does that mean about taking a deep breath? What does that mean in terms of coughing? How can we make sure that you're able to clear secretions that you're needing to clear? And similarly, when we talk about the idea of pressure injuries and wound management, we think a lot about the surgeries that happen. We think a lot about bowel and bladder and the impact that they may have, and making sure that we can keep those regulated to help allow wounds and skin to heal. And we do all of this, why? Because we want to help improve quality of life for those who are living with chordoma. And in addition to doing that with the ways we already mentioned, there's a lot of education that we can do as physiatrists and really providing insight as to what's going on, and also sometimes providing some psychosocial support when it's needed as well. So where do we start? As physiatrists, we start the same way as other medical providers. We ask a lot of questions about what brought you in today. We want to understand your past medical history. We'll ask about medicines. We tend to think a lot more about social history. So not just about alcohol use or smoking, but we're thinking about, where do you live? How many steps do you have to enter your home? Are you a student? Are you working? Are you married? Are you someone's caregiver? Are you a parent? What does that mean? And what does your chordoma mean in terms of your role? We think about where you're functioning now, where you functioned previously, and what it is that you need to and what to be doing every day. And we think a lot about your support system. Who's there to help? How can we engage your family members, your loved ones, those around you to help in the needs that you may have? In addition to the history, we're going to perform a physical examination, and we're thinking a lot about the musculoskeletal system. We're looking at the spine. We look for any kind of postural changes. We think about how the pelvis is aligned and how it's moving. We're going to look at joints in the arms and the legs. We're going to look at bones in the arms and the legs, looking for any kind of abnormalities. We're going to check key muscle groups. And so when we talk about key or non-key, I put this in here because sometimes you may hear it come up. So when we think about the key muscle groups, those are all muscles that are tied to a function. So if we think about the biceps brings the hand to the face. When we think about our finger flexors, they help us to, hold on to things, to grasp items, to hold items. So those are going to be considered the key. And then we have non-key. So we're thinking about bringing our shoulders up or down. We may think about how our legs separate and come back together again. They're important muscles, but not necessarily tied to a key function that we're seeing, but we do assess them both. We want to know about sensation, not only to light touch, so a gentle stroke, but to something that would be uncomfortable, either cold or a pin. And we also check what we call proprioception. Do you know where you are in space? Why is this so important? Because sensation helps us to interact with our environment. And so if we're not sure where we are in space or where we're standing, it's going to be a challenge for us in terms of balance. If we're not sure how tightly we're holding on to something, it's going to impact our ability to pick things up. And also sensation plays a key role in terms of pain that we might be experiencing. We're going to check for range of motion. Is there anything that we're noticing that's abnormal? Is there a restriction that might be impacting a function that you're needing to do? We're going to check cognition. And this is important. Why? Because whenever we're putting any rehab plan into place, we want to make sure that the individual understands what's happening. They're able to carry over. They're able to guide those around them. We check blood pressure and fluid status because we want to make sure that the rehab interventions that we're doing are safe and we're not going to cause any symptoms during them. We check skin. And not only from how can we help manage if there's any wounds, whether it be surgical or whether it be from pressure, but also if we're thinking about any kind of bracing, we really want to make sure that we don't cause any harm in the areas that we're applying a brace to. And then if we're able to, we're going to watch you walk, and we really want to see, are there abnormalities? Is there anything that may increase your risk of fall? Is there anything that we can do to help with that? Beyond that, we talk a lot with the treating teams. We talk with radiologists about what does your imaging look like, why we want to know where the chordoma was located. We want to know about any areas of recurrence. We want to know about any areas that have been exposed to treatments. Are there any fractures that we need to be mindful of? Is posture changing? And is that a sign that there's something else that's going on? And again, something that we need to be mindful of when we're putting a rehab plan into place. And then we're going to look for non-chordoma things that might be happening, arthritis type of changes, everyday wear and tear to the spine or to the extremities. We're going to talk to the treating teams and even use our own knowledge to understand precautions that might need to be placed on activity. We always talk about how exercise is great and therapy can be such a good thing. But we really want to make sure that the things that we're putting into place are safe, that we're not going to cause any harm, that we're not going to make you uncomfortable or provide guidance in terms of exercise that make you feel uncomfortable. We really want to understand where you are in your treatment course, and where if there's any new treatment decisions that are being made. Are you in a time where you're on expected observation? And we want to understand your goals and the goals of those around you. What is it that you want to be doing? What is it that you need to be doing? And we put all these pieces together. Why? Because that's how we establish our plan. And when we establish a rehab plan, really you're at the center of it. So our goal is to help you meet your goals. We also want to make sure that your treating team is on the same page. So we're going to put all that together. We want to understand how your symptoms and various things that we're seeing on your exam are impacting you from a functional standpoint and also from a quality of life standpoint. In terms of the recommendations that we make, so I want to start with pain because I know this is a very common symptom that can be experienced regardless of where the chordoma is located. And so we think about that. We think about structures that are in an area, right? Are we thinking up in the clivus area? We're thinking kind of that, base of skull, upper spine. Are we thinking about the mobile segments of the spine? So the areas of the neck, the areas of the trunk, the areas of the lower part of the back. Are we thinking down at the sacrum, the area that's interacting with your pelvis? We think about the nerves that come off of that area. We want to know what type of pain is it. Do we think that it sounds like a biologic or a tumor type of pain? Do we think that it sounds more mechanical and we're concerned that there might be a fracture in an area? Do we think it's radicular? So is there pressure on a nerve root that's causing the pain? And where is that coming from? Does it match up with an area where you had chordoma, or does it match up with an area where maybe we see some disc disease as well too? After we do our full assessment in terms of where the pain is coming from or why we think you might be experiencing pain, we have a thorough conversation with your treating team. And I can't stress that enough, in that in rehab, we don't practice in isolation. So we always make sure that you, your loved ones, and your treating team are part of the conversations and the recommendations that we're making. And so we'll have these conversations about what is the next best step. What can we do to help? And perhaps, we might say that it is in terms of giving medication to help with the pain. Perhaps it is treating a recurrence or progression in an area. We might think about injections if we're thinking about a radicular type of pain that's being experienced. We do a lot of education in terms of pain that's happening in terms of spine precautions. And when I talk about spine precautions, I think we always think about the BLTs that you get right after surgery, but we also really just think about good body mechanics, right? So I always tell people, think about the dishwasher and the overhead bin and how you're doing those motions. We actually shouldn't flex and twist and extend and twist at the same time. We should always rotate in the midline and then bend and then extend. So if we're putting our luggage in the overhead bin, we should be facing the overhead bin. If we're putting our dishes in the dishwasher, we should be facing our dishwasher. And the last piece becomes that lifting piece, right? I always say that when you are lifting, you never want to lift so much that you have to hold your breath or make funny noises, because that's going to put stress onto the spine. We may consider some postural bracing, some extremity bracing based on findings that we see on exam. In terms of giving support. We'll incorporate our physical and occupational therapy colleagues to help strengthen the muscles that support the spine, and not only support the spine, but also support the extremities, so that we can make sure that we're keeping you doing the things that you need to do. We'll think about nutrition from a bone standpoint, but also from a muscle standpoint, right? We want to make sure that you have the building blocks to help build muscle and also to help tolerate any exercises or therapy recommendations that we make. And then depending on how the pain is impacting, we may think about some adaptive equipment to support while we're getting the pain under control. I don't always know that everyone understands bracing, and I think we think a lot about the big scary braces. So when you think about that kind of clamshell on the mannequin, right? Or that metal and upright type of brace. Those are braces that do exist. Those are not usually the braces that we would provide unless there is some form of true instability. But we think about some of the more backpack style or lightweight supportive braces that we can actually use to help impact in terms of posture. When we think about postural bracing, and if you ever have the need that you have postural bracing, braces are always named by the regions of the spine that they cross. So if it's around the neck, it'll be a CO or a cervical orthosis. If we're thinking about the thoracic part of the spine and the lumbar spine will be a TLO. And if we incorporate down to the sacrum, it'll be called a TLSO. So just some insight into the names that you may hear. Pain and other impairments can actually impact mobility, and we've been kind of touching on this. So that's going to be the next area that we do talk about. Should we see that there's any musculoskeletal abnormalities that are impacting in terms of how we're moving, how we're getting in and out of bed, how we're walking, how we're getting up and down stairs, how we're sitting? What is our sitting posture? We're going to assess for those. In addition to that, now we're going to take it to that next step, right? We're going to think about the neurological system. We're going to think about areas of weakness. We want to understand, where was the involvement? Is it, an upper extremity or lower extremity? Is it both extremities that might be weak? Where are they weak? And how is that impacting your upper and lower extremity weak movement? And how is that impacting that overall mobility and function? Similarly, when we talked about sensation, really that inability to understand and where you are in space or how you're interacting with your environment. Based on the findings that we see, one of the first things that we think about is going to be the idea of physical therapy and occupational therapy, really focusing on a strengthening program, a sensory program, focusing on gait mechanics, focusing on standing, focusing on that sitting position. In addition to that, this is another place that we might think about some of that, whether it be spine, but also extremity bracing. We may think about some adaptive equipment. Oftentimes, we don't necessarily upfront think about wheelchairs, but sometimes there is a need where, especially in the community, if, just doing the therapy or using bracing alone may not actually be enough. And so similar to when we think about the spine and how we name braces, we think about that in our extremities as well, too. And I don't know why my computer is moving so quickly. But we think about an AFO, an ankle foot orthosis, something that might help lift the foot up. If we need to incorporate the knee, we'll add a K, so it becomes a KFO. Similarly, we can brace all the way up to the hips. Obviously, the more that we're bracing, the more energy that is consumed in terms of operating these braces. So it is a conversation to be had, but oftentimes we're not really thinking so much about the KFO and HKFOs when we're thinking about chordoma, but we might see them and we might see AFOs quite a bit. I think a lot of us do understand the various types of adaptive equipment that, may be used or may be incorporated. One added piece that I would say that when a physiatrist is evaluating, we're really thinking about arm and hand functioning, and we're thinking about overall balance when we're making these recommendations, because we want it to be useful, but we also want it to be safe for you to use. And I just want to mention the idea of wheelchairs here, just because it is something that might be discussed. Please know that if there's a wheelchair evaluation that's going to happen, don't just ask for that standard prescription for it. Really ask, for a true wheelchair evaluation. Let it be known the needs that you have. Let it be known the kind of wheelchair that you may be looking for, because there are various types from lightweight to power that do exist, and we always want to make sure that we're making the right recommendation. So just showing you some examples of various wheelchairs, and then finally, thinking beyond just bracing, thinking beyond, canes and wheelchairs, what kind of things can we use in the home that might be actually helpful in terms of mobility and ADL needs that you may have. I want to move on and kind of finish up with the something that I think is very important, but I think oftentimes isn't spoken about enough. And this is the idea of bowel bladder function, and also intimacy and sexuality. And we know that not only with sacral chordomas, this can be something that does come up with chordomas in the mobile spine as well, too. So an important conversation to have. As physiatrists, we can help evaluate bowel and bladder function. We'll think a lot about emptying patterns. We'll try to understand, is it that you're unable to hold? Is it that you're unable to relax to actually empty? And we really kind of focus on that piece to try to help make recommendations that will be helpful to keep continence, because we understand it's not only important in terms of wound and skin, but just in terms of social interactions. Based on the pattern that we may see, we may have a conversation with a urologist if we think it's something beyond what we can help from our scope. We may talk about dietary and lifestyle recommendations, really avoiding bladder irritants, foods that might be helpful, making sure we're staying well hydrated. There's medications that can be offered to help in terms of bowel and bladder function. thinking about the idea of catheterization if it's needed, thinking about pelvic floor therapy. If there is sensation in the pelvic floor muscles and there is ability to contract and relax, this is something that we can enhance and that we can help with. And also thinking about positioning and breathing for emptying. And I put this image here. There is a great guide. It was actually written for traumatic spinal cord injuries on bladder management. And it's actually written for a consumer, so those with lived experience. And it does a great job just explaining how the bladder works, various types of impairments, and various things that we can do to actually help. Similarly, we'll do an assessment for bowel. And I think this is another big place. We understand that not all bowel changes are opioid-induced constipation, and they shouldn't be treated as such. We really should understand, are reflexes intact? Are you able to empty on your own? Why are you struggling? And also, is there a concern about incontinence that's actually happening? We can understand a lot based on a history and physical examination alone about the neurological system, about the muscular system in terms of bowel and bladder emptying. When we can't do it based on that alone, there is additional workup that we can order to help understand bowel emptying patterns. Based on the pattern that we do see, if it's something that is more in the mobile segments of the spine, we think more of an upper motor neuron pattern. When we think about chordoma in the sacral spine, we think of a lower motor neuron pattern, and what we're describing is just where the spinal cord is involved. But our recommendations are going to be based on what we're seeing. When we have an upper motor neuron pattern, we want formed stool, but stool that's easy to empty. When we have a lower motor neuron, or more at the sacrum, we want something that's a little bit more firm or formed so that we can maintain continence, but also help to empty. We'll make recommendations in terms of diet, foods to avoid, foods that may help bulk, recommendations in terms of fiber, hydration. I always say 1 to 2 liters a day is good for bowel and bladder. We might think about some oral medicines to help push things along so that the stool is where it needs to be for empty. We may think about how you're emptying, whether it's positioning and breathing, whether it's using a suppository, or even educating on any kind of manual removal. Depending on patterns we find or how programs are working, we may incorporate our GI colleagues as well. And then I want you to know there is a similar consumer guide for bowel as there is to bladder. Unfortunately, I didn't have a picture of it in this presentation, but just know both of those are free resources on the PVA, the Paralyzed Veterans Association of America website, and they're downloadable. And then the last piece I want to leave you with is don't feel that you can't speak about intimacy and sexuality. It is something very important, and it's a big part of who we are. And so we as physiatrists can help with that conversation. We can help understand things that might be impacting your ability to be intimate, to, engage in sexual intercourse, to have an orgasm, to, thinking about erections, thinking about overall in terms of childbearing, if that's a goal as well too. So there's a good amount of things that we can help in terms of guidance with, help understand. We can also do it not only from the neurological standpoint, but thinking about any skeletal abnormalities and how is that impacting engagement as well. So please be open and know that you can have these conversations with your providers, and it's something that we can help with. There are a lot of great resources that do exist, and it's something that I do a lot of counseling and education on. There's also adaptive equipment, to help in terms of engagement and intimacy. We might think about pelvic floor therapy. Similarly, a lot of our ability to engage in intercourse is reliant on a series of muscle contractions and relaxation within our pelvis. So that's something we want to be able to help with. And then we have colleagues that we can collaborate with as well too, women's health specialists, urologists, reproductive specialists that we can help make connections for and help refer you to. And then I just want to end with providing a series of resources that do exist. I will say that a lot of the resources that are out there are geared towards those who are living with traumatic spinal cord injuries. And I just want you to know that, yes, your experiences are different, but in some ways that there is some overlap and there is some ways that the guidance that we have and the things that we understand in trauma can actually help. And even just provide insight or some resources or someone that you can actually speak to about it. So I want to leave you here. I know we just have a few minutes. I tried not to go too over. I get too excited when I am talking about these things, but I want to stop sharing my screen. And if anyone has any questions, I'm happy to answer them.
Thank you, Lisa. Any questions from anybody? Lisa, was one of the resources that you had on your last slide, was that like a physician finder from a physiatry organization?
So the last one is actually from the APTA, so the American Association of, or the American Physical Therapy Association. I've actually found it to be one of the most helpful resources when I have to find physical therapists in an area. And so it's the APTA website, and you can actually type in all the things that you're looking for in terms of a physical therapist. Occupational therapists have something similar. And then if you go to the American Spinal Injury Association, or you even tap into any of the physical medicine and rehab organizations, even if you were to do a search on it, there are physician finders in various areas who can point you in a good direction. I also always say that a good resource is academic medical centers, because they would know who is in an area. And also, Shannon, I know you and I have worked very closely together through the Chordoma Foundation about finding a physiatrist.
Yeah, and that was a point I was going to make, is that if you're looking for something like this, when you go home from here, going to an academic medical center, I mean, physical medicine and rehab is a department in most, if not all, I would think, academic medical centers. So, these resources are out there, even though we hear from a lot of patients that the awareness of that or ability to find it is a little bit tricky or unknown, but it's definitely there. So
One other place that's really helpful is if you actually go to spinal cord communities. And I think this is a place where there's a little bit of overlap, is because they know all the spinal cord injury providers. So physicians who are like me, or someone who might actually, just be a physiatrist who's in the area, they can actually help point in these directions, because they're pretty good about keeping lists of who's out there.
perfect. Okay. Any questions? Okay, awesome. Thank you so much for joining us. Really, really appreciate it.
You're so welcome. I'm always available. Reach out to Shannon. She's pretty good at finding me, but I hope this just gives a little bit of insight that, you're not alone. There's a lot that we can do to help, and ask for physiatry and rehab, because I do think it can make a big difference in quality of life.
Yep, for sure. All right, thank you.
You're so welcome. Thank you.
Bye.